Good morning, good afternoon, good evening to you all, and welcome to this, our first COVID-19 briefing from the WHO European Regional Office in 2021. A warm welcome to you all. To my left, we have the Regional Director, Dr. Hans Kluge. Also joining him today on the panel are Dr. Catherine Smallwood, the COVID-19 Incident Manager here at the WHO Health Emergencies Team in the European Regional Office. And we're also joined today by Dr. Siddhartha Datta, the WHO Regional Advisor on the Vaccine Preventable Diseases and Immunization Programme. I think the media that are joining us know the drill very well. I'll be welcoming your questions shortly. We've received some questions in advance, but before we go to those, I will hand the floor to our Regional Director to say a few words.
Thank you, Rob. Good morning, everyone. First and foremost, wishing you a happy and healthy New Year 2021. We were prepared for a challenging start to 2021, and it has been just that. 1 year from WHO's first news report about this virus, we have new tools at our disposal and considerably more knowledge. But we remain in the grip of COVID-19 as cases surge across Europe and we tackle new challenges brought by the mutating virus. This moment represents a tipping point in the course of the pandemic, where science, politics, technology, and values must form a united front in order to push back this persistent and elusive virus. The WHO European region saw over 26 million confirmed COVID-19 cases and over 580,000 confirmed COVID-19 deaths in 2020. In the 27 countries that participate in Euromomo's all-cause excess mortality monitoring, close to 313,000 excess deaths were reported in 2020. This marks a threefold increase on excess deaths recorded in 2018 and close to a fivefold increase on excess deaths in 2019. As we enter 2021, over 230 million people in the European region are living in countries under full national lockdown, with more countries set to announce lockdown measures in the coming week. Transmission across the region has sustained at very high rates of infection. As of the 6th of January, among all countries and territories in Europe, almost half have a 7-day incidence of over 150 new cases per 100,000 population, and 1/4 are seeing a greater than 10% increase in case incidence over the past 2-week period. Over 1/4 of all European member states and territories are seeing very high incidence and strained health systems. Where there are signs of stabilization or even decreased incidence in some countries, this needs to be taken with some caution. The impact of the holiday period, of gatherings of families, communities, and any relaxation of physical distancing and mask-wearing behavior, for example, cannot yet be determined. Testing and notification activities may have also been lower during the festive season, resulting in an incomplete picture of the current epidemiological situation. Assessing developments over the coming days before gradual lifting of any measures in place is the prudent approach required. 2021 brings with it new opportunities and tools, such as the vaccine, but also new challenges posed by the virus itself. Like all viruses, as it has circulated, the COVID-19 virus has changed over time. I do understand the concern around the possible impact of the SARS-CoV-2 variant of concern. 22 countries in the WHO European region have detected this new variant. This variant is of concern as it has increased transmissibility, So far, we understand there is no significant change to the disease this variant produces, meaning the COVID-19 is not more nor less severe. It spreads across all age groups, and children do not appear to be at higher risk. It is our assessment that this variant of concern may over time replace other circulating lineages, as seen in the United Kingdom and increasingly in Denmark. With increased transmissibility and similar disease severity, the variant does, however, raise alarm. Without increased control to slow its spread, there will be an increased impact on already stressed and pressurized health facilities. I want to urge countries to mitigate this burden by doing all they can to reduce transmission and increase vigilance to identify any new variants by first investigating unusually rapid transmission and unexpected disease presentation or severity. Second, increasing the sequencing of systematically selected subset of SARS-CoV-2 infections and using this data to inform early on public health measures. And third, sharing this data so that we can better understand the true extent in circulation of this and other variants. Solidarity in science is crucial at this time. This is an alarming situation, which means that for a short period of time, we need to do more than we have done and to intensify the public health and social measures to be certain we can flatten the steep vertical line in some countries which may not have seen it to date. It's the basic measures with which we are all familiar that need to be intensified to bring down transmission, lift the strain on our COVID-19 wards and save lives. Adhering to generalized mask wearing, limiting social gathering numbers, physical distancing and hand washing, coupled with adequate testing and tracing systems, proper support for quarantine and isolation, and increasingly vaccination will work if we all get involved. The deployment of COVID-19 vaccine in the WHO European region has set the ground of using vaccine as one of the tools to contain the ongoing pandemic. There have been reports of various but promising rollout of COVID-19 vaccine in the region. However, whilst I can reassure you that WHO and partners are making huge efforts to get the vaccines into every country, it needs every country capable of contributing, donating and supporting equal access and deployment of the vaccines to do so. Collectively, we simply cannot afford to leave any country, any community behind. Given the limited supply of vaccines and the increasing burden on our health systems, prioritization of vaccination of our health workforce and the most at risk in our communities is vital. Their courage and sacrifice over the last few months cannot be forgotten. It is time to protect and support the frontline workers with the new tools we have. At this point in time, and after so many months in cycles of hope and despair, herd immunity is an understandable desired endpoint. Yet, it cannot be our immediate primary concern. I want to emphasize that vaccine rollouts are essential, first and foremost, to reduce severe disease in vulnerable groups, release the pressure on our hospitals, and avoid the risk of our health system collapsing. Whilst I appreciate that it poses an extraordinary effort, the benefits are phenomenal. Following the WHO emergency use listing last week on the use of the Pfizer Biotech vaccine, the Strategic Advisory Group of Experts on Immunization met on Tuesday to discuss policy recommendations around the use of the Pfizer Biotech vaccine. We have all taken note of the recommendation to make the time between the first and second dose of the vaccine more flexible than what was initially prescribed by the manufacturer. It is important that such a decision represents a safe compromise between the limited global production capacity at the moment and the imperative for governments to protect as many people as possible while reducing the burden of any subsequent wave on the health systems. I wish also to emphasize that this decision has been taken in accordance with already available evidence on vaccine efficacy from clinical trials. Dr. Siddhartha Datta, who is with us, may elaborate on this when we take questions. Be it vaccine allocation and prioritization, access to medical supplies and tests, public health measures and policies to control the pandemic, we have a responsibility to base decisions on the core values that are at the heart of humanity: solidarity, equity, and social justice. It is the only way out of these uncertain times, because no one is safe until everyone is safe. Thank you.
Thank you very much, Regional Director. Right, I'm going to turn over to the journalists calling in online. Let me remind you, if you have a question, please raise your hand in the Zoom system. I've also got some questions that have been sent to us in advance, which I'll pose to the panel shortly. So I'm going to go straight across to Gunilla von Hall. Gunilla, welcome back from Svenska Dagbladet, Swedish outlet. Gunilla, hoping you can hear us, please go ahead with your question.
Yes, can you hear me?
We can, thank you.
Okay, thanks. My question concerns the vaccines and the variants, especially what is called the South African variant. There's some scientists that are expressing doubts that the COVID vaccines will actually work with these new variants, as there seems to be multiple mutations in this spike protein in the South African variant. Do you have similar doubts? Can we count on the vaccines working? If not, how quickly can they be adapted? And what happens to people who already have been vaccinated in this case? Would they have to be vaccinated again? Thank you.
Gunilla, thank you very much. I'm first going to go to Katie Smallwood, and then I'm going to pass the question over to Siddhartha Datta. Katie, please.
Thanks a lot, Gunilla. I hope you can hear me. I'm calling in today. Yes, it's a very good question. And of course, when new variants emerge, and of course they emerge regularly, we're assessing each of them for any public health impact. Both the UK, the variant that was identified in the UK and the variant that was identified in South Africa have both been identified as variants of concern, particularly and initially because of their clear demonstrated increases in transmissibility. In terms of the variant that's been identified in the UK, the variant of concern there's been quite a lot of studies that have already been done by the UK authorities, and they've shared quite a lot of this with us already. There's probably quite promising evidence that the vaccine will work. And at the moment, there is no evidence for any of the variants that have emerged that there would be any decreased effectiveness of the vaccine. But studies are still ongoing, and we expect to hear more as those studies are confirmed and the results are available to us and to the authorities. But for the moment, there's no indication that there would be an impact on vaccine. And I'm sure my colleague Siddhartha would be able to comment on the steps that would be taken if there were. Thank you.
Thanks, Katie. Siddhartha?
Yeah, thank you so much, Gunilla. I hope you hear me well. And just to follow up on where Katie was mentioning that these vaccines are being, what we have developed are based on the spike protein, as you have already mentioned. The current evidence doesn't actually indicate any ill effect on the current existing vaccines that we have on our hand. However, the mutation need to be looked into closely, and moving forward, we'll have to see if there is any effect that would happen on the vaccine. But at this point of time, there are promising evidence that these current vaccines will work. However, we need to keep a close eye both on the mutation and on the effect of the transmission of the virus with the current available vaccines. Thank you.
Thanks very much, Siddhartha and Katie. And I also acknowledge that Oskar Gozinska from the Polish press agency also asked a similar question in advance regarding the South African strain. So I'm going to stay with Oskar because he has a second question, and it's, I think, best responded to by you, Siddhartha. So Oskar is from the Polish press agency. He asks, the UK government has decided to delay administering second doses of vaccines in order to maximize the number of people getting some protection with the first dose. Do we have any data or any idea what effect such delay has on immunity? Siddhartha.
Thank you so much, Oskar, for asking that question. So, as you have heard the regional directors say about the recommendations that the strategic advisory group of experts have made on the dosing and the period between both of the doses. At this point of time, as the strategic advisory group of experts have looked into, the higher efficacy has been shown beginning about 14 days of the first dose and persist up to 7 days of the second dose at 21 days. So these are the periods of immunological response that the strategic advisory group of experts looked into based on the available evidence from the clinical trial results from the Pfizer Biotech vaccine. Nevertheless, WHO acknowledges that number of countries will face exceptional circumstances of vaccine supply constraint combined with the disease burden which is ongoing. At this point of time, there are no specific data that has been shared by the vaccine manufacturers on the long-term safety of a vaccine after a single dose. And within this, exceptional circumstances where countries are considering or may consider delaying the administration of a second dose, mostly on a pragmatic approach, a programmatic significance, to maximize the number of individuals benefiting from the first dose while the vaccine supply continues to increase. We strongly suggest that countries, while making these national decisions, look into the robust evidence which are available or put together a system wherein the robust evidence or the information can be made available for their own decision making. And as more additional data becomes available, WHO will continue to make programmatic adjustment to the dose intervals moving forward. Thank you.
Thanks very much, Siddhartha. Okay, I'm going to go to a question that was posed to us also in advance by The Telegraph, the UK outlet, from Venetia Riney. What does WHO think about the fact that the non-EU Balkan states, except Serbia, currently have no vaccines or timeline for a vaccination program? Given the significant shared borders, should the EU take responsibility to prevent them from being left behind or forced to use potentially unsafe vaccines such as Sputnik 5 or Sinopharm? I'm going to pass that over to the regional director to respond to.
Thanks, Rob. So, absolutely, in the fact that WHO is calling for solidarity in this case means that ensuring a fair and equitable access to COVID-19 vaccine is really at the heart of what we call a global public good. And that's also the principle of the COVAX facility. WHO, with CEPI, with Gavi, is working very closely to ensure that no country is being left behind. And in addition, WHO is working closely with the European Commission, the European Union, on also what we call donation policies to see whether neighboring countries can receive the vaccines which are included in the emergency use of listing or pre-qualified. So indeed, we are very, very well aware about this. But one thing is, again, the access to the vaccine. The other part is what we call the vaccination process, so from A to Z. So WHO, through the regional office, through the country offices, is equally working very closely with all countries in the region, particularly outside of the European Union, on assuring that once there is access to the vaccine, it can be delivered, including issues as vaccine hesitancy, the cold chain, the risk communication, etc. Thank you.
Thank you very much, Regional Director. So I'm going to go back to journalists online. Gabriela Sotomayor from Proceso in Mexico. Gabriela, the floor is yours. Gabriela, hoping you can hear us.
Can you hear me?
Yes, please go ahead with your question.
I'm a Mexican journalist based here in Geneva. I heard this idea of mix and match the vaccines. For example, the first shot with the Pfizer and then the second shot with AstraZeneca or another one. What are your comments on this? Thank you very much.
Thanks very much, Gabriela. Siddhartha?
Thank you so much, Gabriela, for that question. Indeed, we are also learning from several vaccine manufacturers about a potential trial being done with 2 different vaccines. We have heard about the media news about the Gamaleya vaccine with the AstraZeneca vaccine. We are also hearing that there are other potential vaccines being made on trial for mixing and matching to possibly look into the immune response, whether there is any heightened immune response to the combination vaccines when they are being used. There are several principles attached to this mixing and matching. The different vaccines which are currently being talked about for mixing and matching are adenovirus-based vaccines. They have the similar adenovirus base, which is being used for the production of these 2 vaccines. And hence, there are heightened interest from the vaccine developers and manufacturers to see whether this mixing and matching will lead to some dose pairing, or we can save some dose when there is a limited vaccine production or availability of vaccine at this point of time. However, any of these trials need to be done with a very robust protocol in place with an intended expected outcome which is being thought of, and the benefit programmatically also need to be looked into when such mix and matching happens. This is also important to note that when we talk about mix and match, it has to be looked into both programmatic feasibility plus the scientific feasibility of these different platforms of vaccines that are being in development at this point of time. Thank you.
Thank you, Gabriela, for the question, and thank you, Sid. We will now move we're going to go back to Sweden, to Lina Darwood from Expressen TV in Sweden. Lina, your question, yes, please. Thank you.
Yes, Lina Darwood from Expressen here. Since the beginning of the pandemic, it's never been a requirement to wear a mask on public transportations here in Sweden. But today that changes. My question is simply, is it too late now, almost 10 months later, to tell people that you need to have a mask and require it? Is it even worth it?
Thanks very much, Lina. I'm going to go across to Katie Smallwood, please, to respond to that.
Thanks very much, Lina. The short answer is no, it's never too late. And we are always changing our recommendations. And we're changing our recommendations based on 2 things. One, our understanding of how the disease is spreading and how the virus can more effectively spread, such as in the case at the moment in Europe with the potential variant that has been detected in the UK and is known now to be circulating in low levels in several countries. This is a very good reason to up the ante, just as the virus itself has upped the ante. It's not doing anything differently, it's just doing everything better. So must we. And I think it's a good moment to take stock and to look at what we're recommending and to basically say, what more can we do that will be more effective in controlling the transmission of the virus, variant or no variant. The measures are basically the same. The second thing is the transmission scenario and what's going on in the particular context where these measures are being put in place. And there we really need to look at what are the transmission dynamics, what are the measures that are in place, are they working already, and do we need to take additional steps? And I think that's what countries are doing, and it makes perfect sense to do so, whether or not it's 10 months in or 2 years in. Thank you.
Thank you, Katie, and thank you for the question, Lena. So I go to Peter Leonard from Central Asia editor, who's the Central Asia editor, for EurasiaNet. Peter's question regards Turkmenistan. It's rather lengthy, so I'll try and summarize it. The WHO technical mission dispatched to Turkmenistan in July completed its visit with recommendations to scale up testing and send samples to WHO reference laboratories for confirmatory testing. Is it a concern to you that neither of these recommendations have been followed? Your office has cited alleged travel restrictions as an impediment to confirmatory testing, although this is clearly misleading, as restrictions did not prevent the private travel of a team of German doctors to meet the President in November. Has the time not come for the WHO to finally call Turkmenistan out on its continued adherence to its very clear and dangerous misinformation about COVID-19? I'm going to pass this to the regional director.
Right. So it's true that Turkmenistan, as of today, has not reported any confirmed COVID-19 cases. I would like to point out that following the WHO mission in July, the country did put in place a comprehensive set of measures to interrupt transmission of respiratory infections in the community, including with measures related to mass gatherings, markets, public transport. So that's one element. A second element, it's true that I took the initiative together with Dr. Tedros to speak to the President, the Minister of Health, Minister of Foreign Affairs over the summer, where we recommended indeed to have a WHO team and to do a joint sampling and then send the samples for quality assurance to a WHO reference laboratory outside of the country. I followed up also then with the Minister of Foreign Affairs and Minister of Health. And yes, as of today, it's, I would say, rather unfortunate that we don't have seen any concrete follow-up so far, but I would like to reassure you that we continue the open dialogue that we have with the government of Turkmenistan, including through the country office, to follow up on this recommendation. Thank you.
Thank you very much, Regional Director, and thank you for that question as well. So next I'm going to go to Jamie Keaton, Associated Press. Jamie, welcome back. Your question, please.
Hi, thank you very much. Rob, I appreciate it. I actually sent it to you in the chat as well, but I'll read from what I had sent to you. Dr. Kluge, so nice to see you, and Happy New Year. We have seen so many countries in the Europe region enact lockdown and restrictive measures, and yet the rates are still going up in many places. How do you explain that? And what have you learned about which government measures, and I'm not talking about personal behavior like mask wearing or physical distancing, but in fact, government measures, what government measures have turned out to be the most effective?
Please, Regional Director.
Right, and then let's go to Katie as well, Rob.
Yep.
So yes, thank you, Jamie. Happy and healthy New Year to you as well. We're optimistic it will be for health a better year, and all of us, including the media, is working very hard on that one. So, number of points here. I mean, as the jury will be made and come out later, because we have to be very, very careful with making any definite conclusion at this stage, because we're still in the midst of the pandemic. But definitely what we can say is what I call back to the basics. I mean, primary healthcare as the cornerstone of a strong health system is so important, with what we call the essential public health functions integrated. It means like a good community surveillance, so to pick up any unusual events as early as possible. In other words, the combat against the pandemic does not start at the door of the hospital. I think that's, I wouldn't say a new lesson, but a painful reminder in that sense. And then the other one is that it comes back to the core of the European program of work, our vision in WHO Europe for the next 5 years, leaving no one behind. We did leave a number of population groups behind, which now are much better protected, like the elderly. And second, the need to empower the voice of the health ministries and the health people within the government. because we saw this tension, right, between health and science and then the economy. And what we learned is not one against the other. It's not life or livelihoods. And that's why, Jamie, as you know, I established the Monti Commission, the Pan-European Commission on Health and Sustainable Development, which is proceeding very, very fast to make recommendations to heads of state, Minister of Finance, on targeted investments in health and social care as a precondition, not only for health and well-being, but social cohesion, economic development, and as we see now also with the COVID vaccine, for regional and global security.
Katie, can I invite you to add a few words?
Yes, you can, Rob, and I won't repeat anything that the regional director said, but very much building on that and looking at the specific measures. I disagree a little bit. I think sometimes we do forget how difficult March, April were, and how restrictive some of those measures were at the time. And then if we think to November, and when several countries in the European region were seeing very rapid increases, and the measures that were put in place in November, they did in fact bring down transmission extremely well. If you look at countries like France and other countries in Western Europe, transmission rates were changed very, very significantly by the measures that were put into place. In terms of the specific measures, it's difficult to say, and it's difficult to disentangle the impact of one measure versus another. However, there are some basic principles. And what works is basically anything that brings down the number of face-to-face contacts between people, and anything that brings down those specific environments, those contexts where transmission occurs. We may not be able to prevent transmission from happening, but we can certainly prevent those circumstances where transmission occurs rapidly. And that's crowding, that's confined settings, and it's closed environments where people come together. And then the third piece that I would then highlight is critical here, and that's in preventing outbreaks and measures that prevent outbreaks in particular vulnerable groups, such as long-term care settings, in prisons. These can, and mass gatherings, of course, and these can very much inflame and drive transmission in other settings. So rather than focus on the measures per se, it's really the principles behind why those measures are effective that we need to be focusing on. Thanks.
Thanks very much, Katie. Katie, I'm going to keep you on the seat, if I may. There's a question from John Goranitis, Inside Story from Greece. Thank you for taking my question. Some countries, including Greece, are performing less RT-PCR tests and have switched over to rapid antigen tests. What is your comment regarding that strategy, given that the European Commission recommends the use of antigen tests on people already showing symptoms, as the rapid kits are less accurate in detecting the virus in asymptomatic cases? Is it correct to estimate the positivity rate by combining the results from both RT-PCR and antigen test results? Katie, please.
Thank you, John. That's a great question. First of all, RT-PCR, the molecular testing that is conducted, remains the gold standard for identifying COVID-19 in patients. And it's true that it will pick up more infections. It's more sensitive. It will pick up people that are infected over a longer period of time during their infection. Having said that, antigen detecting RDTs are cheap, they're fast, they're easier to use, and they can and should be used not to replace PCR testing per se, but in complement to that. And particularly, they should be used where the virus is known to be circulating. And WHO has very specific guidance for that. The best performance for the rapid diagnostic tests that identify antigens are indeed in patients with a higher viral load. And that's particularly in early symptomatic patients. WHO and ECDC, as you say, have issued guidance, and our guidance is aligned. And in terms of defining positivity rates, these need to be set based on the case definitions. And WHO has recently updated its case definitions for COVID-19 to include antigen detecting RDTs. and that those case definitions should then be used to determine positivity rates. Thank you.
Thanks very much, Katie. So, back to our journalists online. Forgive my pronunciation, Cataldo. I'm going over now to Cataldo Chicolela
Yes.
from RAI. Cataldo, please.
Yes, thank you. So, Dr. Kluge, it has been said to us that the WHO Europe made the decision to pull the report on Italy based on inaccuracies. However, emails from Guerra and you make it very clear that the decision was political because the Italians were disappointed and surprised. What were the political considerations that went into that decision to pull the report, and why did you feel that spiking it entirely was the solution?
Thank you, Cataldo. And let me first and foremost say that I tremendously appreciate the working relation we have with the colleagues, the Ministry of Health, the people, the healthcare workers in Italy. And you may remember, Cataldo, that in fact I was the first one in as early as February who went down to Rome, and I had invited even the European Commissioner, the Director of ECDC, from the very beginning to stand with Italy, and my condolences to all the communities in Italy, country very close to our heart, who has suffered and had people seeing passed away, and my respect for all the frontline workers. So I want to make this really clear. In fact, yes, we distributed a press statement, no, Cataldo, to clarify this, and everything there is, we stand by. So it's true, there was in a particular box, a timeline with a particular country also, where there's something we had to be corrected, and we put it down. I want to make it clear, like I told in the press statement, that at no any time I had any pressure, or WHO had any pressure from the Italian ministry or anyone else to pull down the report. And then there was another process in WHO, which is called interaction review, which took over. So in that sense, there were no any political consideration from my side, but you have to understand, please, Cataldo, that it's true if WHO does an assessment in a particular country, that according to our procedures, we share the report with our main partner, which is the Ministry of Health, not to have any censure or to correct, but to see whether there are any factual mistakes. And this is something that did not happen. So in that sense, this is something that was overlooked and then was being planned, but then taken over by another process. But there were no any political consideration that I can reassure you. Grazie.
Thank you, Regional Director. Next, I'm going to go to Reuters. John Miller. John, can you hear us?
Yeah, thanks for taking my question.
John.
Can you please tell me how the WHO European region is participating in work to clear hurdles for the scientific mission to China? And are you growing concern that maybe political considerations might be playing a role and interfere in finding the origins of the virus?
I think that question's probably best put to headquarters, but I'm going to ask Katie if she wants to add any points on this above and beyond what's already been said in the headquarters press briefings. Katie?
Thanks, Rob. And John, I think both the Director General and Dr. Mike Ryan have been very clear that the mission remains a priority for WHO, and I have nothing else to add at this stage. It's very much a headquarters question. Thank you.
Okay, thanks very much, Katie. I'm going to go to Associated Press, Nicole Winfield. Nicole.
Thank you for taking my question. I'd like to return, if I may, to the issue of the Italy report. There's an email that has been made public in which Dr. Ranieri Guerra appears to be asking Dr. Francesco Zambon to falsify the date, to change the date of Italy's influenza pandemic plan. I'm wondering if you consider that undue pressure to falsify research, and what policies WHO has to make sure that that type of pressure doesn't influence UN research.
Thanks very much, Nicole. Again, this is a correspondence that we're unfamiliar with or not privy to, so I would again refer that question to our headquarters colleagues, where, of course, Dr. Guerra is an ADG, an Assistant Director General, based at headquarters. So I'd refer that question to headquarters in this particular case. So I'm going to move on. Thank you for the question. I'm going to move on to Konstantinos Davanis, who's an EU correspondent in Strasbourg, the Hellenic Public Television ERT. And Siddhartha, this is for you, I believe. All countries need more and more vaccine, but production capacities are still low. You have seen, as WHO, many different vaccinations over the last few decades in different countries, and transport logistics have always been very important. Based on your experience, can you tell us how many % of doses of the vaccines could be lost because of logistical or delivery problems or delays, and especially with the very sensitive ones? Siddhartha, did you get that?
Yeah, thank you so much. Thank you, Konstantinos, for that very important question. You have heard the regional directors say a point on that having vaccine in itself is not the end of a problem. Vaccination will have a big bearing. And within that process, let me try to answer your question in two different parts. Handling vaccine and its associated logistics is an important component to make sure that the vaccine reaches to the end point or the beneficiary for which this vaccine is deemed for. When you talked about the different experiences on WHO's campaign, we have seen that. And these issues about the wastage of the vaccine is very context specific. It also depends upon the vaccine characteristics, meaning if there is any time limit beyond which a vaccine vial cannot be used, or if there are multiple doses in a vaccine vis-a-vis a single vaccine vial dose. So all these factors play a big role in terms of the programmatic elements when we talk about the vaccine wastage. The other part of this entire discussion is around how efficiently a session is being planned so that the beneficiaries who can receive the number of vaccines from a vial dose are present so that there is no wastage beyond the time limit for which a vaccine vial is scheduled to be used. However, let us not forget about this, that whether we have a vaccine recipient, and we should not wait to consider that we cannot use the vaccine because the other recipients are not around. These program efficiencies are part of what the regional director was mentioning, end-to-end support, which WHO, along with other member states, are working on. These are all programmatic considerations which will play a big role in making sure the vaccine is used effectively. You talked about the logistics and delivery. We also are working with our member states to ensure that this logistical delay doesn't allow the vaccine to be wasted. These are precious elements at this point of time when the demand for vaccine is not commensurate to the supply. We have to make sure that all these factors are taken into considerations while planning for and implementation of the vaccination. Thank you.
Thank you very much, Siddhartha. And Konstantinos has a second question, which I'm also now going to pose to Katie. So Konstantinos is the EU correspondent, Katie, in Strasbourg for the Hellenic Public Television ERT. It has been stressed several times in recent days that the coronavirus will not be able to be eradicated with vaccinations, which will protect us for a while, but will eventually become endemic. What does it mean for humanity that the coronavirus will become endemic? Will vaccines offer only short-term protection? Should we go on a lockdown in the future, and despite the immunity, depending on each epidemiological picture of each country? Katie, please.
Thanks, Konstantinos. Again, another really good question, and we cannot predict with any certainty what will happen in the future. Eradication of any disease is a huge endeavor. Has only been achieved once for a human disease, so smallpox. indeed through vaccination, but huge differences between that disease and COVID-19. This virus has emerged, it's spread globally and has adapted very well to circulation among humans and continues to adapt and will continue to adapt. We still need to know a lot about how long the vaccine will produce immunity in humans. We still need to know a lot, and we can't predict how the virus itself will continue to change once more pressure is applied on it. And the vaccine will certainly do that. And we also need to further understand how well people will sign up to the idea of getting vaccinated and seek vaccination. All of these things are going to have a very big impact on what public health and social measures will still be required in the future. But I have to say that at the moment, we are very much in the thick of it. Not only are we in the thick of it, we are probably in the European region in the most acute phase of transmission. And we continue to see really big impact on our hospital wards. And in order to start to change any of that, we really need to bring down transmission and we need to control spread, despite the early rollout of vaccinations. As the regional director said, the first thing that the vaccination rollout will change will not be transmission, but it will be that the most vulnerable people, the ones that we're vaccinating first, won't go on to have severe disease and won't end up in hospital and won't die. That is the first impact, but that's not safe to assume will happen on its own. We still need to continue everything that we have been doing, at least for the next 6 months. And this is the truth. We need to continue, we need to reinforce the virus is getting better. It's shown that it can change, and it can change in getting better at what it already does. And we need to do that too. Thank you.
Thank you very much, Katie, and thank you to Monica for the questions. Thank you to Konstantinos for the questions. Okay, we're going to go over to the Washington Post now. Michael Birnbaum has given us a question in the chat, which reads, "You've previously urged countries to try to avoid closing schools as much as possible. Does the new UK mutation change that recommendation? Do countries need to reevaluate decisions to maintain in-person schooling?" Katie, can I ask you that question? Did you get that question?
I did, Rob, and I'm very happy to start. So the principle for schools has not changed. The schools should be the last to close and the first to open. We value education in our children, and we know that the damage that closing physical schools will have, especially in younger children. And as much as possible, we hope that schools can remain open. Whether or not there is a variant in the discussion, the question is centrally around transmission dynamics. The school will reflect community transmission. Therefore, if there is a need to close schools as part of a range of measures in order to bring down transmission, that still needs to be on the table. In the case of the UK, what we saw was that as the emergence of this new variant was being detected and slowly spreading from low-level circulation into a situation where it was beginning to replace other variants and other lineages that were already circulating, the transmission context was one where there was more or less a lockdown in place in the southeast of England at the time, but schools remained open. So that meant that in the initial phases of the emergence of this new variant, that schools were more exposed to the virus. And that's why we saw an initial bias towards school children or younger age groups being affected. This has corrected itself in due course. So the impact of a variant actually changes very little. It's all about transmission dynamics and how to control it.
Thanks very much, Katie. So next, I have two questions to the Regional Director from Monica Kovacic, who's a freelance TV science journalist working for German TV, ARD, ARTE, ZDF. As European countries have different infection rates and different strategies in defending the corona pandemic, there is a risk of ping-pong effect. Countries with lower infection rates are endangered by countries with higher infection rates. What does WHO recommend to avoid that? I have a second question, but we'll stop there, Hans. If I may ask you, Regional Director, to respond first.
Yes, thanks, Monica. So it comes back to the principle that no one is safe or no one is protected until everyone is protected and safe. And it comes back also to the issue, and we saw an evolution there, of what we call regional policy coherence. That's a very important one, and we saw that this was a bit tough and rusty in the beginning, but there is a good evolution in the WHO European region. And it includes issues of sharing access once and if there is of COVID vaccines, and also what I would call to move towards portability of test results, so that different countries recognize the test results, and other issues. I think this will be a very big stress test to the solidarity, because everyone still remembers the lack of solidarity in the beginning when there was a shortage of personal protective equipment, etc. And now we come to this of the COVID-19 vaccine. And obviously WHO keeps promoting this, but not only promoting, is working with all countries on this solidarity issue, but it will be a test for all of us, and particularly for the richer countries, that ultimately all people who need the COVID-19 vaccine will get it. Thank you.
There's a second question from Monica here for you, Regional Director. What are the most important goals and recommendations of the WHO in defending the corona pandemic in Europe since the beginning of the pandemic until today? I think you partly answered that already. Would you like to add any other points?
Maybe to repeat, Monica and Rob, indeed, I was mentioning about on the health system side, the importance of the primary healthcare and the public health. And here, as a WHO European Regional Office, we're going to take a roadmap to our governing body board in September to the 53 countries on reinventing primary healthcare and public health based on the lessons of the COVID-19 pandemic. And then I was also mentioning about this initial tension between life and livelihoods, that is not one against the other. But we keep listening to the countries. What do they think that could have been done differently for the future? And there I would say, no one got it right from the very beginning. And that's why I don't believe in finger pointing and hard benchmarking. We have to, in a very modest way, learn the lessons to do better, because remember what Dr. Tedros told just before the festive season, that this is not the last pandemic. By 2040, 70% of the world population will live in big cities, and about 70% of new infections are zoonotic, on the interaction between animals and human beings. And that's why the Monti Commission has established also a working group on One Health. Thank you.
Right, so I'm trying to get through a long list of questions that we've received today. I can see we're probably not going to make it before the top of the hour. So I've kind of bulked 4 of the questions here, and I'm going to put this to you, Siddhartha. And it regards, I'll try and sort of capture this. Could WHO Europe provide information about tracking which countries in Europe have begun vaccinations against SARS-CoV-2 virus, and how many doses in each country have been administered? Siddhartha, can you add something that to that question, or respond to that question? Thank you.
Thank you so much, Rob. Yes, so we are very much aware of the vaccination rollout happening in few countries of the WHO European region. And at this point of time, we are planning for 2 different facets of tracking the doses being provided by the countries. We do understand that there is heightened awareness or need on the number of doses to be provided. So there is a mechanism being put together with our European Commission and the European CDC for monitoring the weekly doses of the COVID-19 vaccines being provided. We really appreciate that gesture, and we really are working very closely with the European Commission on that. However, as we talk about the number of doses, having a knowledge about only the number of doses of vaccines being provided is not the end of the monitoring and evaluation which WHO envisages. This involves the entire issue around vaccine safety monitoring, monitoring of the vaccine supplies linked to the vaccine effectiveness, and also going beyond that on the demand and acceptance of the population at large. So as we are talking about the number of vaccine doses being administered, it's extremely critical that we understand that monitoring of the COVID-19 vaccination is much further and beyond only enumerating the number of doses. However, these elements will take time for the countries to report to, but we also urge countries to share this information both between the countries so that we can learn from the early starters as other countries are getting prepared for. So this wider monitoring and evaluation framework will capture the different elements of COVID-19 vaccination. Thank you.
Okay, thanks very much, Siddhartha. I'm going to try and take two more questions. So the first, Tom Magner from Carers World. Tom, thanks for joining us, and I appreciate your question in the chat. I'll read it out. Throughout the ongoing pandemic, governments have rightly praised the monumental continuing efforts of frontline health and social staff, but they persistently fail even to acknowledge the equal dedicated effort of unpaid carers looking after a friend or relative, often 24 hours a day. What is the WHO's assessment of the long-term mental toll on unpaid carers of this lack of recognition, support, and low priority on getting the COVID-19 vaccine? I'll pass that over to our regional director.
Right. Absolutely. Informal health and social carers, in fact, are the largest workforce in that field. But the point here is that WHO has been advocating for the informal carers long before the COVID-19. In fact, it's one of the 8 priority actions in the European Action Plan on Healthy Aging. And I want to take this opportunity to express my most sincere appreciation to this huge informal workforce. About two-thirds are women, daughters-in-law, spouses, partners, often vulnerable themselves to health issues. So we will continue. We don't have concrete data as yet, but we'll be looking at that one. I will continue to advocate financial support, which several countries, by the way, are doing under different strategies, but also moral support, training, flexibility in working conditions, all in line with the European Action Plan on Healthy Aging. Thank you.
Thanks very much. So we have a couple of minutes left. Jürgen Cherry from Net News Malta. Jürgen, please.
Good morning. Can you hear me?
We can. Please go ahead, Jürgen.
Yes, thank you. As the regional director mentioned earlier, some member states may face a problem where the amount of people infected and vaccinations may not be agreeable with each other, where people infected will be too high for vaccinations to start working. Does the regional director suggest any rates or a specific pace that the vaccinations should be doled out in order to avoid this circumstance? Thank you.
I think that's a question maybe best put to Siddhartha and Katie. So I'm going to go to Siddhartha, if I may, in terms of the vaccination, this question, how it relates to vaccination programs and schedules.
Thank you so much, Rob. Thank you, Jürgen, for asking that important question. So let me place the facts first. The immunization system or the health system in different countries of in all the 53 member states in the WHO European region varies widely. And I think it is extremely important that these immunization system characteristics or the health system characteristics of the different member states are integral part of the vaccination strategy for COVID-19 rollout and deployment. Because it's not one size fits all, that all countries will have a strategy which is exactly the same. And hence, it's important that all the different programmatic strategic parameters are put in place in countries before the vaccine is being rolled out. It's extremely important that these preparedness are done quite robust in all the countries. WHO has learned from the data that has been submitted by 41 of the 53 member states, at least at this point of time, of the robustness in the preparedness of the different programmatic elements. So I think it is not a matter of race that which country is moving fast or which country is moving slow. It's a matter of ensuring that systems are in place, number one. Number two, that adequate monitoring is being done in the countries on the use of the vaccine. It will really be not fair for the vaccine to sit somewhere and not being used. But for doing that, this preparedness will be extremely critical moving forward. Thank you.
Katie, do you have any points that you wish to add?
Yes, I do. Thanks, Rob. And just to add, at the moment, there's no recommendation from WHO that vaccination rollout should be delayed due to high rates of transmission. Having said that, it is still the main objective for countries to bring down high levels of transmission. We are seeing extremely high levels of transmission continuing across certain countries in Europe, and we do need to bring these things down, but we can't use that as there's no reason to delay vaccination. WHO has very clear guidance to allow countries to adjust their public health and social measures based on the transmission scenarios. That includes hospitalization rates, that includes positivity, and includes notification rates for cases and mortality. Countries should look at those and look at the measures that they need to put in place, and they should roll out vaccination at the same time. At the same time, WHO is also issuing a whole set of recommendations on how to vaccinate safely, the infection prevention and control measures that vaccinators would need to take. So there's very significant levels of caution that, of course, need to be put in place. Thank you.
Thanks very much indeed, Katie. So I'm going to bring this press briefing to a close today. We've gone through the top of the hour. My apologies to Stefano, Angela. I didn't get to your questions. Please do send them in to us. We'd be very happy to respond, or, of course, respond at the next opportunity. Thanks to everybody that's called in, to all the press today and others viewing this. We'll be sharing the Regional Director's statement and, of course, posting a recording of the briefing online very soon. I'd like to just thank the panel members, the Regional Director, Dr. Katie Smallwood, Dr. Siddhartha Datta, for serving on the panel today, and please do contact us by email if there are any other follow-up questions. As always, stay healthy, take care of yourselves, and we look forward to seeing you next time. Thanks very much.